Learning Plan 7 is Manage Care for Patients Experiencing Problems with Substance Abuse. So, Chapter 22 in Varcarolis is where we are getting most of our information from, substance-related and addictive disorders. So, epidemiology. So, let's think about, you're thinking, what does that mean? Well, really, let's think about the scope of the problem. So, how big of a problem is substance abuse? So, alcohol specifically, about 9% of the United States population, 12 and older. Yeah, that's pretty young, right? 12 and older have substance use disorders. 53% drink alcohol. 23% binge drink, 6% report heavy drinking. And when they do these types of surveys, they're only really taking a sampling of the population. So it's possible. That's why it's kind of an approximation. So about 9% have substance use disorders. Heavy drinking. Women, 8 or more drinks per week is considered a heavy drinker for a woman, and men, 14 or more drinks per week is considered a heavy drinker. So that wouldn't just be like a week at a time, like a week of vacation, perhaps, where somebody might drink a little bit more than usual. It really truly means consistently every week, not just a week here or there when people are on vacation. So that's kind of how heavy drinking is defined. Other substances, 10% use illicit substances. Overall in the United States, 10% of the population. But in age 18 to 25, the number is at 22% of the population of that age range. So late teens, early 20s is using illicit substances. So that's kind of concerning. That's a pretty significant number. And, we have to think about people in that age range as being college age and maybe late high school, early college, graduated from college, starting work, careers, things like that. And also the brain is really still developing. So it's really a difficult time to be using all those substances, and just think about the disastrous effects on people's brains, and college careers, and and work too. So that's a really big number. Marijuana in non-medical prescription pain relievers were the drugs of choice for illicit substance abusers. So marijuana certainly is pretty prevalent, and I think overall people have an idea that marijuana is safe, because you don't hear ever about people dying of overdoses from marijuana. So it's really, people think it's safe and it's harmless, and maybe it just gives you the munchies a little bit, or just you kind of laugh and get silly and giggly, get a little bit of sense of euphoria. You don't hear about people driving under the influence of marijuana too often, having accidents or terrible consequences. So truly, I think that that people really tend to think of marijuana as being just relatively safe, harmless, and just kind of more of a recreational type of drug. um, Non-medical prescription pain reliever. So in other words, the prescription medication is not prescribed to them. So they may be abusing somebody else's um, Percocet or Vicodin, any type of controlled substance. Methadone can be, prescribed to people, but abused by other people. So the point is that the prescription is not for them. They're buying it off the street, or perhaps just stealing it from other friends or family members. I would guess also that marijuana and the non-medical prescription pain relievers are drugs of choice also because they're pretty available. Lots of people um, are on these medications. I mean, they're given the pain relievers anyway. They're given for dental procedures, surgery, all kinds of accidents and injuries. Honestly, sometimes they're given for just about anything. You go to the emergency room and have an issue, and many times you're given prescriptions for for controlled substances that are pain relievers. kind of whether you need them or not. I guess I've personally had that experience a few times, and they've insisted that I take the prescription, and usually I take it and I come home and I rip it up and throw it away because I don't need it. And they don't listen to me that I won't need it. So they're very, very available. And I think probably, I would guess, marijuana is fairly available out on the street. And of course, in Wisconsin, it's not legal at this point in time. It might be in the future, and it certainly is legal in other states too. So perhaps if people have friends or family in other states that are traveling, then perhaps they're bringing it back for them also. That could be an additional way, for people to obtain that. The other illicit substance that is kind of coming into vogue a little bit more and more is non-medical use of stimulants. That has doubled, and that's including stimulants like Ritalin. And I have heard of stories, especially among college students, that people borrow or buy other students' prescriptions for Ritalin. Well, they don't buy the prescription, you know what I mean? They buy the pills, and they're taking Ritalin and other types of substances similar to that, the stimulants for ADHD. They're taking those so they can study longer, get better grades, things like that. It's really kind of a thing in among college students. And I have at the bottom, what about Wisconsin? Well, we are definitely a little bit above the national average as far as drug and alcohol abuse. So we do have to think about what is it in our culture, the culture of our state perhaps, that really makes people prone to use substances, even if they don't have a specific substance use disorder. It certainly seems like there's a lot of alcohol and drug abuse around us, especially alcohol abuse. Think about the environment. Think about how many bars we have, especially in a small area. I can think of Sheboygan. I would guess Manitowoc is probably about the same as far as having a large number of bars for such a small area, and that it truly is part of drinking is part of the culture. So every event has alcohol. And I'm not saying other states don't, because they do, but honestly, coming from New York State, I sure can see a big difference in the culture of where I lived in New York State versus Wisconsin. It just seems to be very much accepted and also just very much available all over. So we do have to look at the environment of where we live and just kind of our whole attitudes about drinking. Lots of people in Wisconsin, you may find this hard to believe, but a lot of people truly don't think beer is alcohol. And I hear that over and over again in clinical, especially. Patients really don't think that beer is alcohol. And they think, well, okay, I guess I should give up the hard liquor, but I can still drink beer. No, they can't. If they really want to recover from their alcoholism, they really need sobriety. So that's something that we really, in this country, in the United States, that we feel is the best way to achieve, to overcome, and to try to manage this chronic illness, because it truly is a chronic illness. It's not something that's just going to go away without the person really working hard at it and paying attention to it, like any other chronic illness that a person needs to manage. But I've definitely heard more than one patient really feel and express that drinking beer is not alcohol and it doesn't contribute to their problem of alcoholism at all. So we do have to kind of look at our state a little bit. The other thing is kind of an interesting comment that a few students have made, where they have gone to the Caribbean and there's been drinking contests on the beach, and they actually told them nope, if they were from Wisconsin they couldn't join the drinking contest, probably because they were told that they were likely to win. So, that's just a little anecdotal, somebody said this, but it kind of makes you think about what kind of reputation do we have in Wisconsin, that people in the Caribbean realize that people in Wisconsin drink and probably have a pretty high tolerance to alcohol. So I just thought that was kind of interesting and thought I'd throw that out there for you, and maybe some of you have other anecdotal stories also. So we really have to think about addiction is a brain disease, and it does need to be managed like any other chronic disease. So this is a little poster from New York State, and I do think that the video that I have, the YouTube video, is really excellent. I know it's kind of a long video, it's about 45 minutes, but it's really eye-opening and excellent, even if you watch the first, I think 25, 30 minutes would be really great because she's an excellent speaker and she really drives home the point of this is an illness, it's a brain disease, it's not a alcohol and other substance is abuse is not a disease of choice. And that's the main point she's really driving home and really talks. She really gets into the physiology of the brain. And you certainly don't need to be memorizing, parts of the brain and things like that. But truly, it is not a disorder of choice. And that's the very first line on page 408 in your Varkarolus. So, and that's something that is going to be really hard to, perhaps maybe hard for some of you to really believe. And especially if you have had people in your life, in your family especially, or dear friends that have substance abuse disorders, it may really seem like they're doing it, it's their choice, they're not doing anything to help themselves, and it can truly be very frustrating. So I really get it if you have any personal experience with people that have addictive disorders. They're very, very hard on the family. It truly is a family disease, not an individual disease, because the effects are far reaching. Not only the immediate family, extended family, friends, perhaps members of their church, workplace, colleagues. It's the whole community sometimes can be affected. So it really has far-reaching consequences. And I know that it is very painful for people to live with people that have addiction disorders. So just, having said that, it is hard sometimes if you do have a very personal feelings of anger, frustration, whatever those negative feelings are, it might be really hard to believe that these are disorders of brain disorders, not disorders of choice. But science is really telling us more and more that they're really complex diseases of the brain characterized by craving, seeking, and using regardless of the consequences. So it's not something that people can just stop. They can't just use their willpower and just stop drinking or stop using drugs just because they want to. I did see a documentary I think it was last summer, called Written Off. And this documentary was told by his mom. So there was a young man actually from Wisconsin. And this documentary, Written Off, really kind of detailed his struggle with substance abuse. He wrote a journal. He journaled a lot of his feelings and thoughts and how much he used, how much it cost, and all kinds of other aspects related to his substance abuse. And then the documentary is kind of written from the perspective of his mother and his dear friends that were very involved in his life. If you ever get the chance to see that documentary, if it's a topic you're interested in, I would highly recommend it. Actually, I believe there's also a book, I think, by the same title. So I believe there's a book by his mother. I think his mother's name is Jane Funk. I'm just not finding it right now. I'm just trying to Google this quick while I'm doing this. But anyways, but Written Off is about Matthew Edwards, and he is from Wisconsin. So if you are interested, you certainly can Google that and find out maybe more information about seeing the documentary or reading the book. But it's pretty interesting, just the amount of self-disclosure that this young man does and the way he really details and outlines his struggle and just the frustration of everybody around him, his friends and family, what they go through too. So truly, again, addiction is a family disease. And the other thing I want to point out too is that, yes, it is a chronic disease. So no matter where you work, you probably will run into people that have issues with addiction, whether it's drug or alcohol abuse. It's funny, your book kind of talks about in that first paragraph on page 408 about how, or maybe it's the second paragraph, how historically people were treated separately. There were in hospitals, they used to have separate units just for people that had addiction issues, and then mental health patients were kind of treated separately on mental health units. And that actually is the way it used to be years ago on 1K. There used to be a little section kind of off on its own that just people with addiction disorders were treated there, and then the rest of people with mental health issues were completely separate. Well, truly, that doesn't make much sense because of the amount of comorbidities that there are with drug and alcohol abuse and mental illness. So it really is much better to have a coordinated effort at treatment and have patients that suffer from these illnesses treated on a mental health unit where they can get help for their addiction and help for their mental health issue, because many times people do self-medicate with drugs or alcohol. They self-medicate their symptoms and their feelings of their distress. They're trying to get rid of some of the difficulties of having that mental illness by using substances. And of course, that doesn't work. It usually makes things worse, but sometimes people stop taking their medications and they'll turn to illicit drugs or alcohol for varying reasons. So I'm not going to, I know that you probably can't see this very well, and it's just a little kind of a snapshot of kind of what she talks about in the video about dopamine. So I think her, in that the YouTube video, Addiction's a Brain Disease, I think her talking about it is much more interesting than looking at this slide here. But I just thought this was just kind of a good snapshot of kind of the 1, 2, 3, 4, 5, 6 kind of steps of drug addiction. So the person takes the drug for the first time. They have this wonderful feeling of euphoria, especially think about the opiate drugs. And then what happens in the brain is that less dopamine is produced because it's like this big dopamine rush, and the brain is kind of like, whoa, calm down, produces less dopamine, and then the receptors are reduced. And then in number 4, you have low dopamine and withdrawal. And if people have low dopamine levels, they just really don't feel very good. And then they're going through withdrawal, and so then they have to keep taking, they try to take more drugs. They do take more drugs because they're trying to get back that really nice high euphoric feeling that they initially felt. And then 6 is just really speaks to the whole cycle of them. They have to take higher and higher doses. They develop tolerance, and they're always trying to chase that initial first high, and then they're addicted. So again, just trying to think about this as not being a disease of choice. And many people will argue, well, they had a choice when they first picked up that syringe, or they first took that first drink, or took that first pill. And yeah, you probably can say that that was a choice. That very first use, they chose to start drinking. They chose to start using heroin or prescription drugs, in a way that wasn't meant for them. Yes, I have read a couple of articles that do speak to that, but the brain does take over. So this is kind of a nice representation of that continued use is not a choice. So some risk factors we have to think about: genetic, neurobiological, environmental, and sociocultural factors. At the bottom of page 412, they talk about genetics, and oh my goodness, those statistics they have are pretty alarming. So alcohol use disorder runs in families, and about 40 to 60% of the risk comes from inheritance, comes from your genes. So that's pretty strong, right? And they even talk about twin studies, and there's a fourfold increase in risk factors. It occurs in children of affected individuals, even when the children are given up for adoption or raised in other homes. So very, very strong genetic predisposition, and it sounds like there is also very strong genetic vulnerability for other substances. Cannabis, cocaine, and opiates definitely run in families, and they're also talking about 30 to 40% for hallucinogens and stimulants, and as high as 70 to 80% genetic predisposition for cocaine and opiates. So huge, huge, huge. So I think that is something that's very important when we're thinking of assessing people. Look at their family history. Ask about if they have a family history of drinking or drug use. Very important things for us to be asking questions about. Neurochemical. So again, neurotransmitters. We have to think about the neurotransmitters are affected, and just how quickly sometimes the drug travels to the brain, and all of the neurotransmitter, the reward pathway. There's actually a nice little diagram on page 413, and honestly, I'm not going to hold you to memorizing the different parts of the brain and things like that. But I think as nurses, we should have an awareness of it, but I don't think that the NCLEX is going to be asking you questions about the parts of the brain and the specific pathways and things. But I do think that as nurses, we need to be assessing the signs and symptoms and asking questions as far as the person's behavior, their drinking, their drug use, their patterns, and just to understand that they have a neurobiological basis. I think knowing that and understanding that will really help us with our own personal feelings that we might have, and also to hopefully decrease the stigma, because these patients are absolutely stigmatized, because most of the general population truly feels that it is the person's choice and they just don't want to stop, and they're just not doing anything to stop. Maybe they're struggling and trying lots of different things to stop, and they're just, some people are successful and some people really have a more difficult time with controlling their substance abuse and managing that. So yeah, so we do have to look at those neurobiological factors. As for environmental, I kind of already talked a little bit about just the prevalence of alcohol use or other drug abuse in a particular community, and just the whole like culture. Just how is it? How accepted is it? And you have to think about, there might be some cultures that you don't even have under sociocultural factors, actually. And on page 414, there's a nice paragraph about that, and they do talk about particular cultures that forbid alcohol. So, and even in the United States, some Christian denominations, Pentecostal, Baptist, Mormon, reject the use of alcohol. And then they also mention some other different types of Muslim majority countries, Pakistan, Libya, Saudi Arabia. They have prohibitions against alcohol. So that's environmental and sociocultural really are pretty closely related. But also other environmental factors certainly will be poverty, and that raises the risk of living in an unfavorable type of living environment, lack of parental supervision, poor education, and impaired support systems are all different types of environmental aspects that can increase the use of drugs or alcohol. And the other thing to think about is peer pressure, especially adolescents and sometimes young adults. Lots of peer pressure for those kids to drink. And then if they also have a lack of parental supervision, that just increases their risk factors. So again, another little kind of chart that I found. So just a little, again, it might be a little bit hard to read, but just thinking about the genetics, the peer pressure, the gender, men are more likely to have problems with drug addiction than women, but The progression of addiction is known to be faster in females. So, kind of interesting gender differences. Home and family, having mental disorder, so having a diagnosed mental illness. School problems, actually, under school problems, they have students that have failing grades, skipping school, poor motivation are likely to become involved with drugs or alcohol, but it's also vice versa. So kids that do become involved with drugs and alcohol sometimes then will suffer from poor grades. So that's kind of a cycle that you might see. So it's not only it's the cause and the effect. So trauma and abuse, early drug use, the earlier the person who uses drugs or alcohol, the more likely they are to become addicted. Again, just having to do with the brain and just the growing, the the aspect of brain growth and development. Maybe wondering how common is early drug use, and honestly, I have heard in reports sometimes on 1K, well, more than once, several times actually, that some of the patients that we see, they started their drug use actually pretty young. I'm thinking 8 or 9 years old even, and sometimes it's the parents that are giving the kids drinks, or sometimes the parents are partying and not really paying attention to the kids, and the kids are kind of going around and just helping themselves to drinks that people are leaving around or whatever. Or sometimes in one case, I do remember specifically, the guy was about 9 years old when I think his dad started giving him alcohol to calm him down, help him sleep, or whatever. So it is something that we really have to think about. As yes, it can happen. We might not want to believe that can happen, but it certainly can. So we do have to kind of think about that early drug use. Boy, when you see that in somebody's history, they started drinking when they were 12, or they started, you know, using drugs at 11, that's pretty alarming. How the drug is taken, so drugs that are smoked or injected enter the brain in seconds and are far more addictive than those you have to swallow and that have to kind of go through, you know, being absorbed and digested through the gastrointestinal tract. So, and the high fades and then leaves that person to use often in higher doses. Again, they're always chasing that first initial high. And I've heard people that suffer from drug addiction say that they never quite get back to that initial high. It just seems like that first high is the best, and then they are always chasing that high. I think they use some other types of language too. Um, I'm not quite sure, but anyways, they never quite get back to that same level of euphoria that they initially had. And of course, the type of drug taken, because some drugs are simply more addictive than others, and they give you a little scale at the bottom. Heroin, cocaine, nicotine, methamphetamine, alcohol, and marijuana is kind of number 6 on that list as far as drugs that are more or less addictive. So I guess we kind of have to think about that too. Comorbidities. So psychiatric comorbidity. In 2014, out of 20.2 million adults with substance use disorders, 7.9 million of those had co-occurring substance abuse or mental disorders. So you can be addicted to alcohol and drugs. So sometimes people are addicted to more than one substance or abuse more than one substance. So we do see the diagnosis, the medical diagnosis sometimes of polydrug use. So that means that they sometimes that they don't even have a drug of choice, but they just use multiple substances. Medical comorbidities can be the direct result of substance abuse, and there's another slide, and we're going to be taking a look at that. So, concepts central to addictive use disorders: addiction, intoxication, tolerance, and withdrawal. So, it's kind of important for us to understand what those words really mean. So, addiction is that term that people commonly use to describe that primary chronic disease of the brain: reward, motivation, memory, and related circuitry. So, again, it's a brain issue, and it's a dysregulation in the hedonic or hedonistic pleasure seeking or reward pathway of the brain. So I'm hoping that you recognize the root word of hedonic or hedonistic when we think of anhedonia, the symptom of depression where people don't feel pleasure. So in addiction, people are feeling pleasure. It's that pleasure-seeking part of the brain. So in addicted individuals, they can't consistently abstain from the substance or the activity. So because we haven't talked about this yet, but people can actually be addicted to different types of activities called process addictions also, but they can't just stop. They can't just stop using on their own. So they actually don't even recognize sometimes the extent to which the addiction is creating a problem in their life. So typically we see people that use in spite of serious types of consequences, and they have difficulties in their functioning. Maybe they're getting fired from their job, they're losing relationships, but they are still using in spite of all those negative consequences. And sometimes well, we'll talk about some um, defense mechanisms, but sometimes it's a little bit of denial and rationalization that gets thrown in there, and they may have other excuses why they think things are falling apart in their life, but they won't admit that it is the drug or alcohol abuse. And with addiction, there's cycles of relapse and remission. So sometimes people can maybe stop drinking for long periods of time. They're kind of in remission, but then they may have a relapse. So that is something also that we as nurses have to kind of keep thinking about. So intoxication is that process of using the substance to excess, and it's going to manifest itself in a variety of ways depending on what the substance is. So if somebody is intoxicated with caffeine, for instance, it's going to be very different from if they were intoxicated with LSD or alcohol. So it really does depend on the substance being used. And then tolerance just means that the person no longer responds to the drug in the way that they did initially. So they never quite get back to that initial high feeling that they first felt, and they have to take higher and higher doses to achieve the same effect or somewhat close. It depends. I think with drugs like heroin, I'm not sure if they ever quite get back to that initial first high. But even think about people that develop tolerance to alcohol and how much alcohol somebody can drink if they have tolerance built up versus somebody that has no tolerance built up at all. Maybe somebody with no tolerance is going to show signs and symptoms of intoxication at 2 drinks, and somebody with tolerance, maybe it's going to take them 5 drinks before they're showing signs of being intoxicated. So again, a little bit variable also depending on the substance, but the concept is just needing to take higher and higher doses. So I had a student tell me once that they worked in the emergency room and saw a very small female patient come in with a blood alcohol of pretty close to 0.5, but I think it was 0.4 or something, and they were still walking and talking and had on stiletto high heels. So that would absolutely be somebody who has developed tolerance. And then withdrawal is just the physical signs and symptoms, or it could be psychological too. We can have psychological withdrawal, especially if there isn't much physical withdrawal involved in the substance. And perhaps I think marijuana is kind of one of those where it may be more psychological withdrawal and less intense physical symptoms, but just the craving and the wanting to use again. But withdrawal, most of the time, we think about physical symptoms that occur when that person stops using the substance, or even if they cut back dramatically. So you can go into alcohol withdrawal if you're a very heavy drinker and you cut back, even if you don't stop drinking completely, you can still go into withdrawal. And again, the withdrawal symptoms are going to be very specific to what type of substance is being used. So it can be mild or it can be life-threatening. So alcohol is considered a life-threatening withdrawal. Heroin is not considered, and other opiates are not considered it's not a life-threatening withdrawal. It is very uncomfortable for people, and many times, even if they're in the hospital and they're getting medications to help them through their withdrawal, there are many times that they just can't tolerate it and they ask to be discharged against medical advice, and you kind of know deep in your heart that they're going to go back out and use again because they're just so uncomfortable. They feel like they've got the worst flu that they've ever had and they're just miserable, and they know that using is going to help them feel better quicker, unfortunately, than maybe some of the PRN medications that we're giving them. So, but it is not a life-threatening withdrawal. Alcohol, benzodiazepines are actually related to alcohol in terms of the way they act on the body, so that could also be considered a life-threatening withdrawal. So, some other concepts. Codependence and enabling. So you might have heard those terms before, and they are different. They're not the same thing. So codependence happens when a person takes responsibility for the person who is addicted, and many times they do things for that person that they should really be doing for themselves, like even something like calling in sick for that person. Maybe they went on a drinking binge on Sunday and they're really hungover Monday morning, and so the codependent person is likely to call their boss and tell them they're not coming in, they're sick for work today, that they've got the flu or something. They're going to probably make something up. They're certainly not going to say that they are, that they have a hangover. So they take responsibility and do things that the addicted person really should be doing for themselves. It also could be taking over different types of household duties that maybe that person should be doing, but you kind of just do it for them because you know that they're using and they're just not going to get around to it. So you better cut the grass, you better pay the bills and do all the things to keep the household running. So instead of making that other person responsible for their behavior, you kind of take responsibility away from them. The codependent person also is the type of person who might be taking the alcohol, trying to look for where it's hidden, and pouring it down the drain. So those types of behaviors are all part of codependence. So in your book, they don't really cover codependence and enabling all that much. So actually, I looked up on a website from the Betty Ford organization. So they really give some nice descriptions. I'll just go over what they say a little bit just to give you a little better picture of codependence. So they think and feel responsible for other people, for other people's feelings, thoughts, actions, choices, wants, needs. And so they're really focused more on the other person than they are on themselves. They are more likely to meet the other person's needs and leave their own needs unmet. They feel compelled to solve problems for that person who is addicted. They give unwanted advice. They try to fix things, like fix the feelings of the person or just, fix situations. They find themselves saying yes when they really don't want to do things. They find it easier to feel and express anger about injustices done to other people rather than themselves. They find themselves attracted to people who are needy, and they look to relationships to provide all of their good feelings. It's kind of like they define their self-worth according to their relationships. Many times, people who are codependent can come from troubled, repressed, or dysfunctional families. They tend to blame themselves for everything, and they just really don't ever think that they're quite good enough. So that same website from the Betty Ford organization talks about enabling, and they describe enabling as protecting the person from the natural consequences of their behavior, perhaps keeping secrets about the addict's behavior from others in order to keep peace. They can also be making excuses. They bail the addict out of trouble. So that's really huge. The codependent person might not necessarily do that. So think about in overall, the enabler is somebody who is helping to keep that person addicted. through their actions, through their words. So if you're bailing somebody out of trouble, you're protecting them from the consequences of their behavior, and you're not helping them at all to take responsibility for themselves. So if you're paying fines for them, bailing them out of trouble, you fix tickets, you hire lawyers, you pay off their debts, things like that, you're helping them to stay addicted. So truly, that is the kind of like the whole concept of what enabling is. Many times the family members do give money that is undeserved or unearned. So they just give them money knowing full well that they're going to use that money to buy drugs or alcohol. So there really is a difference between those two. I can think of a couple of different examples from what I've heard in clinical. There was a female patient who was struggling with alcohol addiction, and she went through withdrawal, and she was doing better, and she was just determined that she was going to really do well this time. So she went home, and her husband apparently had searched around the house and found some alcohol, but of course it would have been a kind of a codependent thing if he had dumped the alcohol down the drain, but it was more of an enabling thing because he put the big bottle of vodka right in the middle of the dining room table. So when this woman walked into her house, that's the first thing she sees is the big bottle of alcohol sitting on the table. So that certainly is inviting her to use and making it easy for her to continue with her addiction. So she did relapse and went back into the hospital again and then told us about the alcohol on the table. So that is an example of enabling. I have another it's kind of a bad example, really a very sad situation that I kind of follow the news in Rochester, New York, because that's my hometown. So there was a very sad situation a couple of years ago where a young woman in her 20s had a 3-year-old, I think she was about 3, yeah, 2.5, 3-year-old daughter, and and then the mom of this young woman was, yeah, probably in her 40s, 50s. So the grandma of this little girl was driving around with this little girl in the car and her addicted daughter, who's in her 20s or so, and to find drugs. And the very sad part about it was, what mother drives their daughter around to buy drugs? Certainly she was probably going through withdrawal and was uncomfortable, but you know what? Not a good thing to do. And the saddest part of that story is the little girl had been abused by the boyfriend of the mom, and she had had abdominal injuries and was really suffering in that back seat and really, fading and just not able to eat. And she was just kind of slumped over and turning white. And they actually ended up, after the grandma drove the daughter around and got her drugs, they actually went to a wedding shower for somebody, and brought the little girl inside, and the little girl is just sitting at the table, not eating or drinking anything, just kind of head slumped over on the table, and not a single adult at that whole event did anything to help that little girl, and she eventually died. And just think about the grandma. You're in your 40s, 50s, and you're driving your daughter around to get drugs, and you don't even notice that you have a very sick toddler in the back seat, and you don't do anything about it. Nobody stepped forward to help this girl. To me, that is like the ultimate epitome of the horribleness that enabling can be. So now we're going to talk about professional enabling. And unfortunately, your Varkarolus book, does not do a very good job with this topic at all. So I looked in your Nice and McEwen, and that is your community book. And no, I'm not assigning that reading kind of this late in the game, but I was really very disappointed. Some of the older editions of Varkarolus really covered this topic quite nicely, professional enabling and also substance abuse among health professionals. It's just not covered very well in Varkarolus at all. So I'm just going to kind of talk about that for for a couple of minutes here. So professional enabling. So that is the concept of a professional person like a doctor, a nurse practitioner, anybody that has prescriptive privileges that over prescribes um, substances that can be abused. So we're especially thinking about this happens very often with addictive substances like the opioid pain relievers. That's probably the most common drug that would be overprescribed. So people that are prescribing in large amounts, way more than people need, and also for longer time periods. And I've seen this happen. There was a woman who came in who was in her 70s and she was addicted to something. She was addicted, I think it was opiate pain. Yeah, it was pain relievers. And she had had a surgery like, I don't know, 9 months ago, and the doctor continued to refill her prescription. So her daughter brought her in. Daughter was in her 40s, and she brought her mom in. Mom's in her 70s, and mom's addicted. So we had to, help her through withdrawal, especially because of her age. And, in thinking about that, why would you continue to give somebody um, powerful addictive pain relievers for a procedure that they had done 9 months ago and they would no longer need that substance? They weren't in pain any longer. But I'm guessing the woman got addicted and she just felt like she needed to take it, probably felt good when she took it. So that's kind of an example of professional enabling. So at the top of page 562 in the Nice and McEwen Community Book, they talk about sometimes that prescribers actually kind of are in a bind because they feel like if they don't prescribe something usually for issues like besides pain, sometimes sleep and anxiety are also um, common issues that patients have. So pain, sleep, anxiety are three big complaints, and there are lots of addicted substances, medications that we use to treat those conditions. And sometimes the prescriber feels like, well, if they don't give them a prescription medication for something, even if it's addictive, they'll probably get something, they'll self-medicate, and they're going to be buying illicit substances on the street, which certainly isn't a good reason to be over-prescribing. However, that sometimes is the rationale or the bind that physicians and other prescribers feel that they're in. So that's part of why professional enabling can happen. So within the past couple of years, there's been some really high-profile, highly publicized events that have happened as far as overprescribing. So I just did a little quick Google search for Candyman drug prescribing. And so I came up with the Candyman doc at the Toma VA here in Wisconsin threatens to sue the whistleblower. That's the name of the article, but I think that was in 2015. And so there was a physician there who was prescribing all kinds of um, powerful drugs all at the same time. And I believe there was a veteran, I'm not going to open up the article now, but I believe there was a veteran who died as a result of being prescribed many different types of drugs, like antipsychotics, probably pain relievers, antidepressants, maybe anti-anxiety, just a whole host of drugs, just over-prescribing and polypharmacy, so prescribing many different types of drugs. That's kind of what I remember. So, and then there was another one in California, pretty much the same thing. And a geriatric doctor was illegally prescribing powerful painkillers that caused at least 20 deaths. And so that physician in California was named the Candyman. So it's definitely something that we have to be on the alert for. It has happened, and hopefully, with different prescribing guidelines for physicians in the last few years as a result of those incidences, that hopefully those types of deaths absolutely should be prevented. But just some really highly publicized examples of that. So that is something as nurses, our role certainly would be, we could certainly be whistleblowers if we really realized that somebody was doing something illegal, unethical, that is within our realm to be able to report that to whatever facility where you work, whether it be a nursing home, a VA hospital, or a regular hospital. So the other issue that I just kind of want to talk about too is a concept that, again, Varkarolus just does not do a very good job of. They have one tiny little paragraph about substance abuse among health professionals. So, which, nursing, we're at kind of high risk for substance abuse problems because, quite honestly, some of us are a little bit codependent. We like to do things for people, we like to take responsibility for them. So, some of those traits might be from our own backgrounds and maybe even what has drawn us into nursing. So, we do have to understand that it is a problem within our profession. And again, Niacin McEwen does so much better of a job talking about this issue. At the bottom of page 565 in the Niacin McEwen book, they talk about physicians, nurses, dentists, and pharmacists are really vulnerable to substance abuse. It could be alcohol, narcotic use. Those things are most common. Certainly could be other substances too. Actually, I've read articles about, this one guy who was a nurse, and he actually wrote an article about his substance abuse and said that he was stealing. He realized that he really reached a low in his substance abuse when he realized that he was stealing narcotic medication and like fentanyl patches from his dying mother. So that really kind of brought things to his awareness how serious his problem was. But there are lots of articles out there about nurses especially who are abusing substances. So we might think, we're knowledgeable about medications, but so we should be immune to that. However, that really isn't the case. We have to think about what are some things that might cause health professionals. And of course, first and foremost is that we have more access because of where we work. So many times people do divert medications for their own use. So lots of different ways that can happen. Sometimes people actually inject themselves with a substance and then fill a syringe with normal saline and give that to the patient. So there are ways to have little accidents happen. The narcotic count isn't quite right, or they do it by themselves instead of doing it with somebody else. They break a vial. Oops, it's broken. Now nobody can count and see how much of that substance is left. So yeah, all kinds of different kind of odd, unusual happenings usually when they're on duty. And many times, especially a nurse who would be addicted, they might show up on their vacation to try to pick up some extra shifts, or they always want to manipulate to get the narcotic keys if it's that type of system. Now, probably having a Pyxis type system probably helps with that, because in the old days, we used to have a box with narcotics, and somebody would be assigned to carry the keys to the narcotics, usually the charge nurse. So that was certainly an easy way for somebody to say, well, I'll be in charge, I'll volunteer, I'll do it, I'll take that responsibility. But you have to be kind of suspicious if somebody is just wanting that all the time. Now, the Pyxis, it definitely seems like it would cut down on miscounts and things like that, and people diverting controlled substances, but it still happens. So we have to be very careful when we're using that Pyxis and we're taking out controlled substances. So in clinical, I'm going to want to count that controlled substance with you and make sure that it is really accurate, so that we don't get in the middle of something else that might already be going on with with one of the staff on the unit. So we really do have to kind of think about this as this is an issue. So what do you do if you happen to be working with a nurse and a nurse shows up and you smell alcohol on their breath, or they just seem like maybe their pupils are pinpoint, or maybe their pupils are really, really dilated, and you're kind of wondering, and they're maybe slurring their speech a little bit, or their ADLs aren't quite right. You just kind of suspect something. So you absolutely need to do something about it. We want to try to do that in the kindest way possible. If that person doesn't accept feedback, then it's certainly okay to call the nursing supervisor. And actually, they should probably be called anyways, because that person, they need to really deal with that issue. So your job as a nurse is to protect the public. And if by calling a nurse on the carpet who is using substances and showing up to work intoxicated or under the influence of something, we're protecting the public, and that is absolutely what we need to do. We certainly want to help the person who is addicted, and the State Board of Nursing usually tries to rehabilitate that nurse and try to get them into treatment. So by using things like employee assistance programs, referring them to detox and rehab types of treatment, because it would be nice to be able to rehabilitate that nurse and kind of hang on to that nurse. It really depends, though, on the severity of what they were doing. If somebody stole lots and lots of fentanyl patches, or large amounts, if they really diverted large amounts of narcotics, then yeah, it's possible they may lose their license. Or if they stole a bunch of things, well, diverting and stealing, I guess that's kind of the same thing. So diverting is using it for your own use rather than giving it to the patient. So think about some other things that you as a nurse would pick up on. So if patients are consistently complaining of pain or lack of sleep or anxiety when this particular nurse is on duty, even though maybe medications are documented as given, you might be a little suspicious and think, well, maybe they didn't. Maybe they got a Tylenol instead of a sleeping pill. So, it's very possible that something suspicious is going on. The other thing they talk about on the top of page 566 in the Nice and McEwen book, really an interesting aspect, is that sometimes it's hard to get this population into treatment, so medical professionals, because they have a lot of denial and a lot of shame related to their substance abuse. Here they are in a helping profession. They should be helping other people, and they're addicted. So they may really feel that sense of shame and feel that they are a failure. So, but the possible loss of their license or ability to practice might be a good motivator to kind of get them through that denial and really encourage them, to seek treatment. So, just a couple things I wanted to mention, because truly it is an important issue in nursing. And again, bottom line, we need to protect the public from people that show up to work that are under the influence of anything. And we also need to be aware of if we see professional enabling and people getting prescribed too many substances, large amounts for too long of a period of time. So lots of things for us to be aware of. Some defense mechanisms that are used. So I kind of talked about a little bit already, a little bit about denial. So sometimes people are just absolutely in denial that they have a problem with their substance abuse. So they deny the problem exists at all, or they just deny the severity of it. I don't have a problem with my marriage because of the alcohol. It's that my wife is really a nag and she irritates me. So, they're gonna actually the rationalization part of it, is they're going to make an excuse why, but the denial is like, no, it's not the alcohol, it's not the drinking, or it's not me. And then the rationalization is all the excuses. And sometimes I've really heard a lot of interesting rationalization over the years. One of the most profound that I remember was a patient who would talk about how he just did not want to go through any more treatment Forget AA, forget any type of support group or any type of treatment because he knew more than all of the counselors put together. Oh my goodness. So that's, part of that's, a little bit of kind of denial in there too, but a lot of rationalization, just like, nope, he had to rationalize and say why he couldn't go into treatment, why he didn't want to go to a support group, why he didn't think AA was going to work for him, because I know more than all the rest of the counselors and instructors. I know more than them, so I don't really need that. So yeah, that definitely can get in the way of that person getting treatment. Or again, just rationalizing why they use. So my job is really hard. I'm under a lot of stress. Everyone irritates me. My kids are going through the teenage years and they're driving me crazy and that's why I drink. So, lots of different ways that they can rationalize. Displacement is just putting their feelings onto somebody else. So really they may be angry and frustrated at themselves, at their own inability to stop using, and they're going to take out their feelings on somebody else. They may even blame somebody else in their family. So again, we have to look at that family. It's a really difficult thing that they're going through, and they are often the target of displaced feelings of anger, frustration, resentment, whatever. They're being blamed for things when they really don't need to be. So that is a lot of displacement that is happening. Undoing, sometimes we see in terms of perhaps a patient when they are under the influence, they're very perhaps angry, maybe even physically, verbally abusive to people in their family. And sometimes undoing happens when they are sober and then they kind of feel a little bit guilty about what went on, especially if they heard about it or they remember any of what happened, and then they may try to undo by being a little bit extra nice, buying gifts, things like that. Really similar to what we're going to talk about when we do the domestic violence learning plan. So a little bit of undoing sometimes we see there too, with trying to kind of make up for some of their really difficult behaviors. So, substances that lead to use disorders. And I have in parentheses, be aware of street names, because the street names, they do have some names, street names in your book. However, the names are always changing. They're always thinking of new names to call these different types of drugs. So we have to be aware of what is new and current. The other thing is, if you were all sitting in front of me right now, I would ask you, who do you think would be the best person to talk to and ask about what's currently going on in substance abuse in your community? So, well, since you're not sitting in front of me and I can't hear what you're thinking, I'm just going to tell you, and it is your local police officer. So they are very knowledgeable. They know exactly what's going on in your community and why, because they're seeing it firsthand. They're right out there in the midst of it. So they know if it's heroin that's being abused, or if they're starting to see more cocaine. They know why people are starting to use that. When meth started to make a comeback, they knew exactly why, and they know how much of that is going on in your community. So truly, make a friend of somebody in the police department and ask them every now and then, as a nurse, what's going on in my community as far as substance abuse. So it was interesting that, every time a police officer comes onto the unit, or actually I've got a couple of neighbors too that are police officers, so I kind of pick their brains every now and then, so that I can share things with you. So it was interesting a few years ago why people started turning to heroin. And it truly was because they changed the formulation of some of the narcotic pain relievers so that people couldn't crush them and get an instant high any longer. So then they started using heroin. So I thought that was really interesting that they have all all that street knowledge about what's going on. And then, a few years after that, of course, we all know heroin has gotten a lot of attention, and a lot of people are afraid of heroin because you hear about deaths, you hear about people dying, and you hear about or people having to get Narcan and just barely being able to be revived. So people started to get scared of using heroin. Not that it's gone away completely, but the use at least started to decline for a little bit. And then people were turning back to meth because they didn't think that it was as dangerous as heroin. So heroin got the bad rap as, oh, that's the dangerous drug. I'll just use meth or cocaine, because all of a sudden, in the last probably year or two, saw a little bit more of an increase in cocaine again, and hadn't really seen cocaine for a while when heroin was more prominent. So anyways, things are always changing. We have to be aware of street names and be aware of what's going on in our community. And these are some basic classifications, but every now and then you might see some things that are really kind of different and odd in your community as far as types of substances that are being abused. So a few years ago, there was a young gentleman who came in with intoxication and actually acute psychosis from chewing on moonflower seeds. Now, moonflower is, go ahead and Google it. It's a beautiful flower that I guess blooms at night. That's why they call it moonflower. But apparently, if you chew the seeds, it's pretty much of a hallucinogen. So people that are chewing those seeds are getting that type of an experience, kind of an out of body, not sure what they're doing type of experience. And this young man was picked up naked in the middle of a road, just not knowing where he was, what he was doing, and he came to the hospital. So they brought him to the hospital, and they figured out. I'm not sure how they figured that out. Anyways, so that was something that was kind of happening. It started, I think, in the Ohio area, and then it started kind of growing throughout the United States. I literally haven't heard anything about this now for several years. The other thing is salvia, which is a plant. So sometimes we have to worry about what's in our landscaping and think, is there something in my landscaping that actually somebody could chew on the leaves or seeds and actually have a hallucinogenic experience. So yeah, so we do have to be aware of just different things. The other thing that's kind of a concern can also be the synthetic marijuanas. Those can actually be quite dangerous too. I haven't heard as much about those recently as I have a few years ago. So anyways, tobacco, alcohol, cannabinoids, opioids, stimulants. I have caffeine in parentheses because in the very large purple table of different substances, I'm not quite sure why, but they kind of left caffeine off of that list. So, and the list, the big purple table, it's about 3 pages long, starts on page 410 in Varkarolus. So now we're back to Varkarolus. I don't think I have any more references to the Nissen-McEwen book yet in this learning plan. So they do go through and talk about tobacco and cannabinoids, opioids. I'm not putting all of that information onto slides, PowerPoint slides, because my goodness, this PowerPoint then would be probably 100 slides long. So it will be important for you to kind of go through that list, and certainly some of the things are really more obscure that I won't be asking you test questions about. So when I send out kind of a review for the next exam, I'll kind of tell you what things to really focus on. So certainly, certainly look through that list, and they do give some of the street names. If there's Schedule 1, 2, 3, 4 types of drugs, that's kind of listed, and the acute effects and the health risks. So again, I'll kind of tell you, I'll send out a PowerPoint and kind of tell you what to focus on. But it is interesting looking through the different types of substances, and some of those you probably have heard of, and something like classic hallucinogens, other compounds actually includes anabolic steroids. So some people aren't aware that steroids can be addictive and that people do abuse those. So speaking of schedules of drugs, you're probably somewhat familiar with that. So on page 410, they go through schedule 1, 2, 3, 4, and 5. So schedule 1, high potential for abuse and have no medical use whatsoever. So examples include heroin and LSD. Schedule 2, high potential for abuse and considered dangerous and available only by prescription. So methadone, Demerol, Ritalin, those types of medications. Schedule 3 have a low to moderate potential for misuse and available again only by prescription. Testosterone, acetaminophen with codeine, and Suboxone. Schedule 4, low risk drugs available by prescription again. So Xanax, Ativan, Darvocet, some of those medications are considered Schedule 4. And then Schedule 5, they contain limited quantities of certain narcotics for the treatment of diarrhea, coughing, and pain. So Lomotil, for diarrhea, Robitussin AC, which has some codeine in it, and Lyrica, which is, it says Lyrica is available over the counter. I don't think so. I don't know. That's what your book says. But I know that we count Lyrica. It is in Pyxis and we count that. So it does have some potential abuse, but certainly not as much as some of the other ones. When you're looking at that purple table, the 3 pages again, page 410, 411, and 412, do pay attention to the acute effects and the health risk. Again, caffeine, for some reason, is not on there, although they do your book does kind of go on and on about how, caffeine is such a widely used substance throughout the world, but they don't really tell you too much on, they kind of left it off. But anyways, so when people are using too much caffeine. So actually you can have caffeine intoxication. People can be restless, nervous, excitable, insomnia, so just lack of sleep, flushed face, diuresis, GI disturbances, muscle twitching, rambling flow of thought and speech, tachycardia or cardiac arrhythmias, periods of inexhaustibility, which of course is not, again, good for your heart, psychomotor agitation. So lots of different effects that you can get from too much caffeine. And of course, we can also have caffeine withdrawal too, which is no fun if you've ever had that. Okay, process addictions. So we can not only be addicted to substances, but we can be addicted to other things. And this is just a short list. I'm sure that you can probably think of some other ones. Gambling, and I believe your book says that gambling was one of the first process addictions to actually be recognized. Internet gaming, using social media, shopping, sexual activity, exercise might be another one. So again, we're going to see exercise and actually eating behaviors can be also addictive. So people can be addicted to food. They can be addicted to, to eating. They can be addicted to starving themselves. So we're going to see again a lot of crossover between this, the compulsive behaviors, and the eating disorders when we get to that learning plan. So just so that we don't think that you can't be addicted to a behavior, you certainly can be. And they actually have 12-step groups for gambling. They have Gamblers Anonymous, they have Overeaters Anonymous. I don't know if they have any internet gaming or social media. Maybe they should have a Facebook's Anonymous group. But anyways, my husband probably thinks I should be part of if they had a support group for Words with Friends Anonymous, I would probably need to be part of that. But anyways, so just so that we're aware that it's not just substances, but we can be addicted to different types of activities. And, maybe if you think of something really interesting that I didn't mention, just go ahead and shoot me an email. I'd love to hear about it. So, just to kind of pique your interest a little bit, NASA actually performed some experiments in, I believe it was 1995, and they gave spiders different substances. And the spider webs on the left-hand side of the next couple of slides is going to demonstrate a normal spider web, a spider that is not under the influence of any substance. And the one on the right is going to be the substance that we're talking about. So the first one we have here is a spider web spun under the influence of caffeine. The cells were disorganized and lacked a normal hub and spoke pattern. So that's kind of a bad looking spider web. And it's funny because we do think of caffeine as that pick me up, got to have my caffeine first thing in the morning. And we think it's going to help us to function and to it's going to increase our concentration and we're going to be able to do more, stay focused. After looking at this, I'm kind of wondering about my cup of coffee in the morning too. And maybe should I be drinking something else like water or milk? But anyways, I just think this is really quite interesting, and you just kind of wonder, truly, is there a correlation between this? I'm not sure. Quite honestly, I just think it's rather interesting. You know, a correlation between the effect on a spider versus the effect on a human brain. So I was kind of disappointed that this is what the caffeine spider web looks like. This one is under the influence of benzodrine, which is kind of a stimulant, and it was woven energetically without planning or attention to detail. Okay. So again, you take a stimulant and you think you're going to accomplish all kinds of things and everything's going to be wonderful and organized and neat, and it's not. So spiderweb spun under the influence of marijuana. The spiders were easily sidetracked and left their webs unfinished. So again, just another little possible side effect of the medication, and I think we probably can make a correlation between this and human behavior, but just kind of interesting. The spider web spun under the influence of LSD actually had more geometrically regular patterns than when they were sober. So I think that's kind of interesting, and hopefully we don't take out away from this that LSD is good. That's a good thing for the brain. I'm sure it's not, but that's just kind of an interesting finding. And the spider web spun under the influence of chloral hydrate, which incidentally is no longer available in the United States. These spiders gave up even faster than those that had cannabis. And chloral hydrate is a medication used for sleep. It is no longer used in the United States. I do remember years ago when I first started my nursing practice in 1981, we used to use chloral hydrate a lot. Just about everybody got chloral hydrate for sleep at night. The other use I think of chloral hydrate, I believe they would also use that to sedate patients before, to calm them down, kind of sedate them before surgeries and other types of procedures. But I never worked in surgery, so I couldn't, stake my life on it. But anyways, again, kind of interesting. So, all right, so the clinical picture, let's look at caffeine, the most widely used psychoactive substance in the world, and it can result in intoxication and absolutely withdrawal. So I don't know if any of you have ever experienced caffeine withdrawal, but you get a really wicked headache usually, and sometimes just fatigue. You're tired, you just don't have any energy, and really just can feel pretty miserable, unless of course that would be going cold turkey. But if you are gradually decreasing your amount of caffeine, you can kind of avoid the worst part of that withdrawal. But of course, it's not a life-threatening withdrawal. It's just, again, very uncomfortable. Might make it, if you have a really bad headache and fatigue, it might make it really just difficult for you to get through your day. One thing that's interesting about caffeine is that really more research needs to be done to really see if caffeine fits the whole picture of addiction the way that we have just described as far as other drugs, like the use in spite of consequences, that somebody would continue to use more and more to get the same effect. Some of those other, things that we just talked about as far as abusing or being addicted to a substance. So, yeah, not quite sure that, some of those always fit. I'm just kind of reading another article recently that just kind of talked about that they really need to do a little bit more research on this to really see what the severity of symptoms, and just to see if there is that persistent desire to control use, substance use substance use continued despite knowledge of having psychological or physical problems, things like that. So anyways, it is just something that's kind of interesting to think about. The other thing to think about with caffeine is just that it's not just coffee. I think we probably more think about coffee. Some teas have some caffeine, sodas, and probably a larger proportion of people, especially younger people, drink energy drinks. And many times, young adults are even mixing energy drinks with alcohol, maybe to kind of modulate the effects of both. So feeling like they're taking those two together, that one is going to offset the other, and the intoxication, the symptoms aren't going to be quite so bad. So that is something we really have to think about and look at carefully too, especially when we're assessing our younger patients. Can actually be very helpful for energy drinks and sodas and coffees and things to put labels as far as the milligrams of caffeine, but not all of them do. So we should really be trying to teach, especially our young adults, that to really watch the numbers of milligrams of caffeine that they're getting, and to be aware of what the limits are. So safe limits of caffeine can be up to 400 milligrams a day for healthy adults, 200 milligrams for pregnant women, up to 45 to 85 milligrams for children, depending on their weight. So it is certainly something that can potentially be problematic and even dangerous, especially thinking again about the cardiac effects of caffeine. So, yeah, we should really be still taking this kind of seriously. And the other thing I like to point out in clinical is that the patients can order up to 9 caffeinated beverages per day, 3 per meal. That's an awful lot of caffeine. So we should be doing some teaching about how the caffeine is interacting with their medications, and probably counteracting some of them. So if they're on medications for anxiety, caffeine, 9 caffeinated beverages a day is going to kind of, have a very um, difficult effect, of course, on their anxiety, and probably just kind of wipe out the effect of their anti-anxiety medication that they're taking. So, important teaching points for us. Cannabis, marijuana, the most widely used illegal drug in the world. So, and it's the 4th most commonly used psychoactive drug in the United States after caffeine, alcohol, and nicotine, all of which, of course, are legal. And then marijuana is illegal, except that in some parts, actually, in some parts of the world, it is legal. I believe it's legal in Jamaica, and I believe it's legal in probably at least one or more other Caribbean countries. And again, some of the states in the United States have legal marijuana. Even if it's medical, it's still the same, basically the same drug. So very, very widely used. The thing about marijuana, too, besides what's in your book on that purple table, is that many people, again, really don't think it's very dangerous, and or take it very seriously. But it actually can be a drug that kind of, once people start using marijuana, they may start using other substances, because they're looking now for something maybe a little bit more dramatic as far as an effect. And you'd never hear about anybody overdosing on marijuana. I read an article some years ago that talked about how many tons of marijuana that you would have to ingest or smoke in order to overdose, and that it's almost inhumanly possible or not humanly possible to overdose on that. So, hallucinogens cause a profound disturbance in reality, and so that's usually the experience people are looking for. They're looking for some kind of a hallucination experience, out of body experience, those types of things. Sometimes they even describe it as wanting to like open up their mind a little bit to thinking about things that they normally don't think about. So that's kind of what they're looking for. Inhalants. So we think about solvents for glues and adhesives, propellants, thinners, fuels, and most inhalants are things that are found around your house, or they're easily found in a store. So it's very important for nurses to be aware of and do teaching on different types of inhalants that kids might be using for I say kids because it mostly is um, adolescents, and young teenagers, late childhood to young teenagers that are using this because they don't necessarily have jobs and money where they're going to be buying illegal drugs. They are going to be looking for something that's kind of readily available in their own home. So years ago, we used to see a lot more patients come in with huffing, which is basically um, inhaling the fumes from spray paints. I haven't really seen too many people doing that recently, but definitely young adolescents is an age range that we need to be paying particular attention to. And people can die. They can, again, I don't think that because it's something you can have around your house or buy easily in a store without, having an ID or whatever, that it's, maybe they don't think it's anything that's too serious, or it just kind of gives you a little bit of a lightheaded buzz, but actually they can be cause severe respiratory illnesses and problems and death. Opioids, so heroin and other prescription drugs. So there is pharmacologic treatment for opioids for people that are addicted, usually methadone. So people can be on methadone maintenance programs and they go to a facility, usually a clinic, and they get their daily dose of methadone. Many times it's in a liquid form so that the patient can't give it to somebody else or stockpile it or save it or anything like that. Buprenorphine and naltrexone. See, I said it wrong. Naltrexone. So those are other medications. Naltrexone is called either Revia if it's oral or Vivitrol if it's an injection. It's the same medication. So you notice that I just kind of stumbled over the pronunciation. And so on the next slide, I have another medication listed in bold red because these are look-alike, sound-alike meds, and it's very easy to mispronounce and talk about the wrong medication, and they're quite different. So Revia, I do see that ordered in the hospital, and that's to help people with their cravings. And Vivitrol, I have not seen that used. It's a very expensive injection. We started using it a few years ago and then in the hospital, and then all of a sudden we didn't see it anymore. It might still be given in outpatient clinics, but we don't see it in the hospital. Haven't seen it now for years. It's about $800 per shot, but the shot would last for about a month. And if the person were to drink when they were taking the Vivitrol, they would not have any positive effect from the alcohol. So there would be no motivation to drink. They would have the negative effect. So if they tried to drink too much and get a high or get a buzz, they wouldn't feel anything. They would just get the negative effects. They'd get the hangover. So Vivitrol is very effective, and you don't have to take it every day. The injection would last for about a month, but very, very expensive. And not sure if all insurances would have covered that. I do see Revia given as a oral medication in the hospital actually quite a bit. So naloxone, which is Narcan. So again, have to think about pronouncing things correctly. So Narcan is naloxone, and that reverses the effects of opiates really quickly. The person might need more than one dose because sometimes maybe the half-life is you give them a dose of Narcan, they kind of perk up a little bit, but the half-life is longer than the effect of the Narcan, so they may need another dose. And be aware that the person might be angry, in pain, or withdrawing upon awakening, and they can awaken actually pretty quickly. They still need emergency care. Even if you're out on the field and you give somebody Narcan, you, they still need emergency care. You should still always be calling 911, even if they disagree with you. I would just call anyways and get that person to care because they may still continue to have some difficulties. And it really gets to be very sticky because the other problem is that once they wake up with a Narcan, sometimes they're very angry that you ruined their high and they may want to go out and use again. So if we can try to get them to help, that would be the best possible outcome. Another medication is called Suboxone, and that's kind of a combination of naloxone, which is Narcan, and buprenorphine. Just starting to see this being used in the hospital. So it is usually the times I've seen it, it's like a film that just dissolves in the patient's mouth. So again, making it very difficult to divert. So you can't give it to somebody else. You can't cheek it and save it for later. It's just going to melt in your mouth, pretty quickly. So the buprenorphine part of the Suboxone can be addictive. So usually the goal would be to get that person on, wean them slowly and get them on smaller and smaller doses. So we do have to realize it is addictive, and that's part of the reason why the film works really well, because it dissolves really quickly. Medications that are used to treat addictions usually are more successful, like methadone therapy or Suboxone, much more successful if used in combination with counseling. Clinical picture: sedative, hypnotic, and anti-anxiety medications. So these medications can be abused. Benzodiazepines, benzodiazepine-like drugs, carbamates, barbiturates, and barbiturate-like hypnotics. When you hear the word hypnotic, usually what they mean is something that is used to induce sleep. Again, withdrawal to these types of substances can be life-threatening, especially the benzodiazepines. So it is something that as nurses, we really always need to make sure we take a history and see how much of these types of medications that people are using. Sometimes people get a prescription and they are supposed to be taking it, but they take too much. So if one Ativan makes me feel good, I'm going to take 2 and I'm going to feel even better. Or perhaps it's only ordered PRN and they're taking it on a regular basis. So we really do have to think about, and especially when people are using these medications long term, truly anti-anxiety medications like benzos should truly be given short term. We should not be giving those long term. However, that is how some prescribers are giving those to the patients or prescribing them for long-term use. So we really have to watch for signs and symptoms of withdrawal. Stimulants, so amphetamine type, cocaine, or other stimulant drugs, they're second only to cannabis as the most widely used illicit substance in the United States. So your book describes that people feel superhuman while using these. They might be hypervigilant, sensitive, anxious, tense, and angry also, but they're really using it because they want to feel elated, euphoric, sociable, have lots of energy, accomplish things. So again, we have to think about students using things like Ritalin, Concerta, all those different types of stimulants that we use for attention deficit disorder. Your book describes long-distance truckers, students studying for exams, soldiers in wartime, and athletes in competition as using these drugs. Oh, and that just reminds me, actually, I do have a YouTube video that I will show you. Sorry, you're going to have to wait until intermediate clinical. And on Monday afternoons, when we get together for about 3 hours, one of the videos that I will show you has to do with a well-known, well, he was well-known years ago, I guess, in the 80s, sports figure who actually used cocaine in order to have a tremendously successful football game. So, anyways, that's all I'm going to tell you right now. So, you're going to have to wait. But, anyways, so stimulants. I just have a couple of pictures that I kind of found on the internet, just thinking overall about what people go through and how they feel. Sometimes people can express themselves really well in pictures. And I noticed that on 1K, they encourage people to draw pictures from time to time. And actually, there's a lot of really interesting pictures inside the 1907 Club in Sheboygan. And that is basically a place where they hold Alcoholics Anonymous and Narcotics Anonymous meetings and family meetings and things. And I went there for a conference once and just looked around, and they have all these pictures framed, and they're very similar to this. And the next one also, just very poignant as far as the struggle that the person is going through. And this is another one, just don't let drugs keep you from your dreams. And that person is really feeling pulled in two different directions. Just another slide that I got off of the internet too, just so as a little cue to remember, kind of to look at eyes when we're doing assessment and what types of eye issues are going to come with different types of drugs. So constricted pupils, we sometimes also call these pinpoint pupils: heroin, morphine, oxycodone, fentanyl, methadone, codeine, and hydrocodone. So all those types of medications, you're going to see constricted or pinpoint pupils. Sometimes you just see red eyes with marijuana, possibly cocaine or crack, especially if they're smoking it. Sometimes benzodiazepines or the depressants can also, including alcohol, can cause redness of the eyes. Now, when your pupils are dilated, that's usually from things that are going to rev you up. So amphetamines, cocaine, crack, hallucinogens, and sometimes opiates also, heroin, marijuana, speed. So all those types of things can cause your pupils, to be dilated. Oh, you know what? I'm noticing on this that heroin is kind of listed twice. Usually, you are going to see heroin with the pinpoint pupils, not usually with enlarged, dilated pupils. So, the clinical picture, alcohol. Actually, what I think I'm going to do, this recording is going a little bit long. I'm going to stop and continue with this slide in the next recording.